Um, okay, that's good. So, Shell, you're recording now?
Your best interests. That's why it's gotta be.
Yes, I'm recording.
You're a CFP professional, and let's make
Let's
a.
see here. We need to turn off the TV. Who is
40 emails.
Every day your team gets sucked into English
Nick
writing.
Patel is the one who's turning a TV here. Okay, good. Let's go ahead and record the session. I need to record it and see if I can record it from here too, in case. Yeah, let me go ahead, stop sharing here, and then do recording here too, so we can record both in case something happened. But I don't know, let me see here. Yeah, recording. And we can record in this computer. Okay. I think we are ready to start. As I said, today we are having 2 hours of CME for a topic or title. It's called Rewriting 6-Hormone. Rewriting 6-Hormone protocols from just balance from BHRT, which is bioidentical 6-hormone therapy, into balanced bioidentical 6-hormone therapy, which is BHRT. I think that's what the difference between us as CDP MCS and other groups or previously, that the way that has been managing 6 hormones, they give pellets of testosterone, and without the consideration that testosterone can be converted to testosterone, can be converted to estrogen. I think we need to go through to the disclosure just to make sure that we understand that this is a CME 2-hour session. And we are not going to have any business promotion thing here. And I would like people who are helping me here to make sure that they are controlling the room. But as I said, we will be recording this session for education and quality improvement purpose only. It's a CME, a credential information. The content of this activity does not relate to any product or a commercial interest as defined by the ACCME. Therefore, neither the planners nor the faculty have relevant financial relationship to disclose. Basically, we are teaching 6-hormone, and anybody can learn it and apply those information in their clinics. Statements of accreditation. Mini Great Lake ECO is accredited by the Michigan State Medical Society to provide continuing medical education for clinicians, and it's for physicians, nurses, and any healthcare providers. And I think it's coming from AMA, 2 AMA PR category 2 credits. We're doing the same thing with Dr. William Bill tomorrow. He is also having 2 hours of CME, and we provide a CME for Dr. William Bill, and also possibly with other groups as well. And we can also provide it for international conferences if needed. Okay. What is the objective of the presentation is optimizing the BHRT management to equip healthcare providers with the knowledge and the tools necessary to effectively manage the BHRT, focusing on case-centered learning and group discussion. That's what we're doing, I think, in every sessions that we have. It's more about us learning from each other, right? And discussing and be more, in the mood of two-way of learning, not one way. And that helps to verify the information, because if you just, if it's one way, then it's not been verified by the doctors who are in this group. So we need all those doctors to be critical, whether it's negative or positive, both it's good for verifying and review those information. The hormone level review, the second thing about the objective, to review and understand the desired level of various bioidentical hormones and dosing strategies, and that we're going to have clinical cases for that, around 10 cases. Hopefully we can finish them today, to achieve optimal patient's outcome. And very importantly, that we are teaching balanced bioidentical sex hormone, not just bioidentical sex hormone. We know that bioidentical is good, better than synthetic, because they are more biologically friendly, and their metabolites can be you can easily get rid from it or recycle them. But those synthetic, their metabolites, sometimes they are not biologically friendly, and they may cause side effects and may compromise the mitochondria or causing some clotting problems, coagulation effect. Bioidentical has less of that problem because they are biologically friendly with our human body, because they're coming from the plant-based most of the time. And the body can easily degrade them or recycle them without the problems that we face from synthetic products made from the lab. Very important that we need to understand what kind of lab need to be used for assessing sex hormones. And sometimes we add thyroxine level and iodine because, the fatigue, it could be due to low thyroxine. Symptoms could be from the low thyroxine, but also it could be because of estrogen dominance. Both can lead to brain fog. And so in order to differentiate between these two conditions, we will recommend adding or testing the thyroid, the TSH and T3 and T4. We're going to see that in the cases. But also, when we do the sex hormone, we need to do a comprehensive sex hormone. We need to understand that when you're trying to test the sex hormone from the blood, you may not be able to monitor the progesterone, especially if you're giving progesterone topically. They don't show up in the blood, so we prefer using either capillary blood or saliva testing. It's better when you're trying to monitor the efficacy of your treatment, especially if you want to measure the progesterone. You want to make sure the ratio between progesterone and estradiol is above 100. That's very critical, and that's part of the plan to balance the sex hormone. And also in men, you make sure that the testosterone to estradiol ratio is above 20. And also you can measure the ratio between the estrogens and estradiol, and we prefer it's going to be less than 2. And we're going to learn that when we go through all those cases. So we need to learn how to interpret the results of the sex hormones. And we also need to understand that both cortisone and sex hormone, they're coming from cortisone, and the pathway is called steroid pathways. And if you can see here, this is the cholesterol, and cholesterol ends up into pregnenolone, and then pregnenolone, they have two choices. It become either progesterone ending up into cortisone, or they become DHEA and androstenedione, and they will end up into sex hormone, testosterone, and then testosterone to estradiol, or testosterone to estrogens. Of course, in the ovary, you will be converting testosterone into estradiol. What's the difference between ovary and the testis? In the testis, they have less active aromatase enzyme. And so most of the testis will release the testosterone more than estradiol. But in female, the aromatase of the gonads is more active, so you will be converting more testosterone to estradiol. And very important, the aromatase inhibitors, including progesterone and all these aromatase inhibitors, they don't affect the gonadal aromatase. They only affect the tissue or the fat aromatase. And there's a difference between the gonadal aromatase and the fat aromatase. So when we say progesterone inhibit the aromatase, we are saying it inhibits the aromatase of the fat. And when we say anastrozole and all those aromatase inhibitor, iodine, they really affect more the aromatase of the fat, not the gonad. So that's very important. So don't be afraid of giving aromatase inhibitors. And we can start with progesterone. We can start with DIM, we can start with iodines. And then if all of this does not work, you may end up with anastrozole. But let's start with things that's more biologically friendly. And that's what we do when we lay down the protocol of chronic disease prevention. We start with, the more biologically friendly products, and then we escalate into what needs. If it requires big pharma, we go ahead, but we try to use as much as lower dose as we can. Again, it's very important to understand the pathways here, and I think I learned that from Dr. William Bill. He likes this pathway, and especially the three forms of estrogen, which is estrone, estradiol, and estriol. And we know that we have those hormones, especially the estradiol and estrogens, with a little amount of estriol, especially when post 50. There's not much of estriol in our body, so female or male, but we have a lot of, for especially for female, they have estradiol and estrogens, and male we have also estradiol and estrone, but it's not as much as the females, because we work on, the male is testosterone dominant, female is more of estrogen dominance. And we understand why, because of aromatase of the gonads. It's more active in females, so they transfer all the testosterone into more of estrogens. And it's very important to have testosterone in men, and the ratio of testosterone to estradiol has to be above 20 in men. And the reason, because if you end up giving female sex hormone, too much of it to male, and you're trying to transgendering them, and the testosterone estradiol ratio is below 20, which is, trying to feminize the men, it definitely leads to metabolic syndrome, and also cancer. So that's the problem with transgendering. Why? Because men has more receptors of testosterone than estrogen. And we rely on testosterone as men to express antioxidants and anti-inflammatory. And we know that too much of estrogens can definitely cause prostatic hypertrophy and cancer, and too much of estrogen in man contracted testosterone lead to metabolic syndrome. So in order to protect men from metabolic syndrome, they need to have testosterone. Testosterone is the one that helps us to protect us against metabolic syndrome. Female, they need estrogen and estradiol, because that will help them to be protected against metabolic syndrome. So low sex hormone for both sides can lead to metabolic syndrome. And if you start transgendering and giving opposite hormone, then you will end up with metabolic syndrome, because we men, we depend on testosterone to express antioxidant, to increase the sensitivity to insulin. And for female, they have enough of estrogen receptors, because that's how they've been equipped to. And the estrogens are the one who will increase the sensitivity of insulin by increasing the expression of antioxidants. And if you switch that, and you start giving male hormone to female, transgendering them, then they have a high risk of metabolic syndrome, because estrogen will counteract the effect of testosterone. And the same thing for the other side, if you give them testosterone, it will counteract the effect of estrogen and its antioxidant effect. And those patients, they end up with metabolic syndrome. So it's very critical that, if you do the transgendering thing, you need to understand there is induction of metabolic syndrome and also cancer, especially for men. And the reason, because, the testosterone or estrogens, or excessive amount of estrogen lead to estrogen dominancy, and that stimulate or turns into estrogens, and that leads to prostatic hypertrophy and cancer, and estrogen in general, too much of it, that's not being counteracted. Estrogen, or especially what we call the estrogens. Estrogens is inflammatory and proliferative. And if it's too much for both male or female, they can induce endometrial cancer, prostate cancer. And so how we can prevent that from happening? Iodine is a good answer, because iodine will convert the estrogens to estriol, even to convert the estradiol to estriol. And estriol is differentiating agent. So it will balance the proliferation agents of the estradiol and estrogens. And also it's anti-inflammatory. So this is the bad guy. We can move it with iodine, and estradiol can go to estriol. So that's one way. The other way to prevent estrogen dominancy, whether it's female or male, you give them progesterone, because progesterone will inhibit the conversion of testosterone into estrogens. And that's what exactly we need for both female. So when we give estradiol to female, we make sure we give progesterone. And what will be the dose? I mean, I'll go with, the same ratio, we say above 100, right? So go with that ratio. So if you're giving progesterone 50 milligram, then you give 0.5 milligram of estradiol. And that gives you that 100. And possibly if you go with, just make sure the ratio is there and it's above 100 to 100 when you give those topical. And then you can monitor the level of progesterone and estrogen that you're adding by checking your salivary hormones, not the blood, because the blood will not show the progesterone. And we learned that from the previous lectures. But you can use salivary or use capillary blood. There is a test, a way that you can, it's remotely, you can collect capillary blood. The patient can stick it on their shoulder and they can draw capillary blood remotely without the need of nurse or a technician to withdraw the blood. It can be done with a collection system. Something I learned when I was in this conference. But so that's what we need to monitor. You can start with blood testing, but I think it's better to do the capillary blood testing, and then you follow up with, because salivary is more affordable and more cheaper, you can follow up with salivary. And the ratio is the same. You keep the ratio of progesterone to estradiol has to be above 100. And then for men, the testosterone to estradiol above 20. And make sure the estrogens and estradiol ratio is below 2. So I think we learn, and we know that, if you have too much of estrogens, this estrogens is inflammatory. Yes, it's proliferative. It drives the whole inflammation, and also it drives the steroid pathway to make more of cortisol. And when you have too much of cortisol, you end up with cortisone dominancy. And then cortisone also, it does stimulate the aromatase, and it causes more conversion of testosterone to estrogens. So they are supporting each other, estrogens and cortisols. And what will happen? You have inflammation coming from estrogens and proliferation, and also you will have the cortisones, which trying to antagonize that inflammation. But what's happening here, the estrogens is causing proliferation, and the cortisone is suppressing your cytotoxic T cells and compromising immune surveillance, and that put the patient at risk of cancer. So it's very important to prevent that switch from 6-hormone dominancy into estrogen and cortisone dominancy, because that's where we put the patient at risk of cancer. And that's the reason, possibly one of the reason that, when we go above 50, we have the increased risk of having cancer, especially for men. Every year, or every 10 years, it increased 10% of having prostatic hypertrophy and cancer. So at 70 years old, you have 70% of either having cancer or prostatic hypertrophy. 80 is 80% of having cancer tissue and prostate. 90, you will have 90%. And most of the time we said that the reason of this is more of estrogens is stimulating. So you make sure that the patient has the balanced 6-hormone. You make sure the patient is being given progesterone and enough of testosterone to prevent that estrogen dominance syndrome and prevent the switch from estrogen dominancy, the 6-hormone dominance before 50, to switch into cortisone or estrogen dominancy. And how we do that? By doing the balanced 6-hormone. Because we know that 6-hormone in general, if it's balanced, it is regenerative. And what would happen if you switch to cortisone dominance, the cortisone is degenerative. So think about it. The reason why we degenerate when we age, because of the switch from 6-hormone dominancy into cortisone dominancy. And that switch needs to be stopped. So giving 6-hormone most of the mainstream medicine, even other integrative doctors, think it just helps to increase the performance of the sexual drives, and that's what they think, and it's a luxury thing. No, it is essential thing. If you want to slow the process of the aging, and you want to slow the process of degeneration, and also you want to lower the risk of having cancer, then giving a balanced sex hormone is essential and critical to prevent the switch from sex hormone dominancy pre-50 into cortisone dominancy. And we know cortisone dominancy will suppress your cytotoxic T cells and compromise your immune system and put the patient at risk of having cancer. Plus the estrogens, that's dominancy in those cases. They can lead to proliferation and without being balanced with differentiation of the progesterone or the estriol. So we need to make sure that we balance it and we shift the sex hormone forms into estriol using iodine and prevent the testosterone and estradiol from converting into estrogens. And that can be done by giving progesterone and iodine, and possibly by giving polyphenols as well. And by weight loss. Very important is weight loss, because if you don't do weight loss, then whatever sex hormone you're giving, the excess of aromatase and the fat will turn it into estrogens. And so it's when you're giving sex hormone, make sure you also is followed by program of weight loss. Now, weight loss program, you can use the GPL1, which is glucagon-like peptide 1, glucagon-like peptide with glucagon-like GLP-1. Whether the semaglutide or tirzepatide, but make sure when you use those hormones, you use it in a conservative way, and you give the patients, B6 and possibly iodine, and you balance the sex hormone, you give them progesterone, because those hormones or those peptides can cause excessive proliferation in the pancreatic duct. It can cause pancreatic obstruction, and the patient can end up with pancreatitis and full-blown diabetic mellitus. That's what's happening to some of my colleagues, relatives, or spouse. So we make sure that we add or we give amino acids, we add B6, we give multivitamins when we're using this. The other option, there is a drug out there or supplement that it stimulates the physiological amount of the GLP-1. There is some supplement, regardless of the name. What's the name of the flower for the GLP-1 that is the pop flower? Hope flower. It's called Hope HOP. I'll find it. Extract of hope flower. I think it's called hops HOPS.
Called amarasate.
Right. It's
AMARASATE.
Right. That's the ingredients, but it comes from a flower. It's called hops flower. That's where it comes from originally. That also helps to stimulate the GLP-1, which is glucagon-like peptide 1. So you can use that extract from that flower, or you can use the acarbose because it inhibits the amylase. You can use amloxanox, naltrexone. I think as a combination, and then you also need to use some probiotics that secrete butyric acid to put the inflammation of the visceral fat down. Bidifibactrum is one of them. I think they secrete butyric acid, and that helps to decrease the interleukin-7 and the inflammation of the gut and the visceral fat, and that helps the mitochondria to be activated and definitely help to get the fat out, and possibly transform the white fat into brown fat by activating the mitochondria and decreasing the inflammation. So those are the steps the options that we have. Either the GLP-1, glucagon-like peptide 1, or using hops extract, flower extract, that helps to stimulate the GLP-1 naturally, or you you can use acarbose, amloxanox, naltrexone in a very nice diet, or you can do it in a combination. That's the best thing. So you don't need to have, I think the best way is to really combine all of this. Why then you don't need the monotherapy? You don't need just the GLP-1 if you combine it in a way that makes sense. We also want to try to, and I think there's companies, they're trying to do intranasal GLP-1. So that's something that they are trying to do. I think that's a good thing to do also. So those are the things that we suggest for the doctors to do for their for that weight loss. And I think I talked about the ingredients, in other words, without mentioning the brand names. Because we were trying the best for this CME without promoting any specific product here. Again, we can use progesterone oral dose 25 to 400 milligram. I don't like to give oral sex hormones because I don't want to stress the liver. So anything that's intranasal or topical or sublingual will be better. So topical, you can use up to 100 milligram a day, not just 60. Estrogen, I like to use the bi-estrogen, which is estradiol and estriol. The tries including estrogens, but if you just use the bi will be the best because eventually they will convert to estrogens. Oral estrogen, I favor topical, and topical is you can go from 0.1 milligram per mil into 1 milligram per mil, but you can start all the time in 1.25, and then you can go up as needed. Testosterone oral, yeah, but I prefer topical. Topical, you can do 50 milligram to 100 milligram per mil. But you can use all oral and sublingual as well, but I like topical for testosterone. It stays in the fat, slow release, so the best option is topical. And again, you can use from 50 milligram per mil into 100, depending on the case of the patient. And of course, for female, you use lower dose, maybe up to 10 milligram. But male, you can use up to 100 milligram. Transdermal film, yeah, you can use all of that, but just topical compounded sex hormone will be the best option that I think for men, even for female, and along with intranasal progesterone will be the best too, because you get the progesterone into the blood and you get into the brain, and you benefit from the effect, the GABA effect of the progesterone. So intranasal, when we grow up above 50, what the problem we have is sleep problems, right? So progesterone helps us in sleep because it stimulates the GABA, but also it will balance the estrogens and its proliferation effect, also balance the estradiol proliferation effect, because it provides that differentiation effect, and that's very important, along with iodine. So if you add in your regimen progesterone and iodine, I think you will do good in preventing the estrogen dominancy, along with weight loss. If patient has weight loss, it's very critical, and we have all the tools for that. Whether supplement that stimulate the glucagon-like peptide, GLP-1, or GLP-1 itself peptide that's available. And we start trying to, maybe we'll start doing something that's called intranasal GLP-1 instead of injection. And you can use also acarbose and naltrexone and metformin as oral cocktail. And also you can use bidifibactrum as a probiotic to secrete butyric acid, which helps to decrease the inflammation of visceral fat. Again, we need, when we do sex hormone, and I learned this from Dr. William Bill as well, we need to be more comprehensive in making sure we do the saliva-free testosterone, because high level may indicate a condition like hypothyroidism or use of anabolic steroids. Low level could due to hypogonadism. So doing those tests, it just gives us where exactly the problem is. And it helps us in the differential diagnosis. Saliva total testosterone, similar to free testosterone, abnormal level can due to various conditions, including endocrine disorder or obesity, so the same thing. Serum 6-hormone binding protein could be high or low, and if it's high, it may be associated with liver disease or hypothyroidism, and if it's low, it may be due to obesity or hypothyroidism. So it's very important to test this so we can know exactly where is the problem. Is it the problem in the gonads not producing testosterone, or the other systems of the body which is affecting the sex hormone binding? And if it's too high, then that's mean it will collect all the testosterone, prevent and decrease the amount of the functional testosterone. The patient have the symptoms of hypogonadism, but not necessarily it's coming from the gonad. It could be because of the high sex hormone. It's not allowing, it's binding with all the sex hormone of testosterone. There's no free ones that will produce the action. And then here we think that we need to look at, that's the reason I think we need to check the thyroid function and possibly check the liver function and do a complete metabolic panel, just to make sure that we cover the condition and disease that may cause increase in sex hormone that has nothing to do with the gonads, could be systemic disease as liver or hypothyroidism. So that we will be not shooting in the dark, thinking, well, his testis is not produced. Well, his testis is producing enough testosterone, but the problem is the increase of the serum sex hormone binding, and it's because of the liver disease or hypothyroidism. That's why when we check and we do the lab, and I like to be thankful to Dr. William, you know, he asked me to add more tests so he can really understand the patient better, and that we will not be in a position of shooting in the dark. Saliva progesterone, as I said, progesterone, it's better to be detected in saliva and capillary blood tissue or capillary blood, because and when you give topical progesterone, they don't go into the blood, they stay in the fat tissue and they slowly release, so you don't get it to see them into the blood. So when you do the testing, and that gives us difficulty to monitor the efficacy and the ratio that we are talking about, keeping the progesterone estradiol ratio above 100. And that's the reason we recommend to do capillary blood testing. And there's a kit that you can stick it on the patient and it will withdraw, and the patient can do it. You know, you don't need to have a technician, and just stick it there, and then there will be a vacuum tube will suck the capillary blood. It's not IV blood, it's not venous blood, it's capillary blood, those bloods, and you can detect the progesterone by that way, or you can use the saliva testing. I like to do the capillary blood the first, just the base, and then follow up with salivary testing, because it's more affordable, the kits of salivary, and the salivary progesterone ratio will be enough. But then after maybe 6 months or 1 year, you want to do the capillary blood again, that's fine. Yes, there are some issues about, they say, well, capillary blood is more precise and more accurate than salivary. Yes, but when we monitor, we don't, what's important is the ratio. And you can just do once a year of capillary blood, and then the rest every 3 months you can use salivary because of its convenience. So we can, so here we go, you know, if the salivary progesterone is abnormal in male, and this is what's happening if you have abnormal sex hormone in male, by the way, it may be due to congenital adrenal hyperplasia or adrenal tumors. You know, it's very rare to see a normal person with high progesterone unless they give them too much of progesterone, which is us as doctors. But if it's high and it's not due to us giving it, then we need to check if there is any adrenal hyperplasia or adrenal tumor, because we know adrenal tumor can be source of sex hormone. We know the adrenal gland secretes sex hormone. And we know that when when their ovary is not producing enough of sex hormone, what will happen? Your adrenal gland will kick in and start producing both sex hormone and cortisol, but it's not enough of sex hormone as you used to, but more of cortisone to take care of the inflammation. And again, the patient will be switching from sex hormone regenerative dominancy pre-50 into cortisone dominancy, which is degenerative. So saliva to estradiol high level may be caused by obesity, or alcoholism or glandular dysfunction, and low level could be due to hypogonadism. This is for male again, and we know why, because mostly it's not estradiol, it's estrogens. Estrogens in male, and I think we need to check that. Estrogens will be high in men because testosterone will be converted into estrogens. And that's the reason we need to manage obesity as much as we can. Before, we can't give sex hormone at the same time. You need to work on the weight, because if you give sex hormone without working on the weight of the patient, then all the sex hormone that you're giving is going to be converting into estrogen, and you will have patient estrogen dominancy. So I recommend strongly that part of the sex hormone, and everybody who's doing sex hormone, they have to do weight loss. And if they're doing sex hormone without weight loss, they're shooting in the dark. They don't know what they're doing, and actually they may induce estrogen dominance in that men and cause prostatic hypertrophy and causing all kind of cancer, because the testosterone that you're giving to those patients are converting into estrogen and leads to estrogen dominancy, especially the estrogens. And so again, elevated estrogens means that the patient is obese, and sometimes it could be due to certain tumors. Saliva estriol, it's not that you don't see it much in the body or when you test them, but we know the idea that giving iodine will help to move the estradiol and the estrogens into estriol. Why it's not detected in the blood? Maybe because it converts, so it's degrade, and it has a short lifespan. Maybe that's the reason. But we don't see them much. But we know the iodine would help, and estriol is a good thing, right? Because estriol, it's anti-inflammatory, and it is differentiating, and that's what you need when those three forms. You make sure that's being balanced, those three forms of estrogens. And you need to have enough of estriol to balance the proliferation effect of estradiol and estrone, especially the estrogens. And you can do that by giving iodine. DHEA is good to be measured. And if it's high, that's possibly you have adrenal tumor. Or in female, you may have the polycystic ovarian syndrome. Or if it's low, then possibly you have patients that adrenal insufficiency. Saliva cortisone. We know if you have estrogens too much, you may have also high cortisone. Why? Because estrogens moves your steroid pathway to make more of cortisones, and cortisones cause induction of aromatase and causing the testosterone and the estradiol to move more into estrogen. So they are actually feeding each other, and the patient may end up with estrogen dominancy, and they will end up with cortisone dominance. But elevated cortisone also could be because of steroid use, or could be because of adrenocorticotrophic hormone secreting tumors. So all of this needs to be investigated when you are checking the level of the sex hormone. I like to add the cortisone plus adding thyroid hormone. Again, in females, saliva-free testosterone can be high, may indicate a condition like hypothyroidism or use of anabolic steroids, or the woman is being given too much of testosterone. Low level could be due to hypogonadism or aging. Yes, when we age. So possibly if their testosterone is too low, we may need to give them testosterone. And testosterone helps in giving the women the orgasm effect. Same thing for men. If their estradiol is low, and I learned that also from Dr. William, that estradiol helps to stimulate the high density lipoprotein, which helps to clear the body from cholesterol. And so it's very protective. But we need to keep the estradiol within the normal range, which is around less than 30, around 30 for men, around that. If it's getting low, like 2 or 3 or 4, we do recommend adding estradiol. Same thing for female. If their testosterone is too low, then we recommend giving it. So that helps the woman to have some orgasm. And so balance in sex hormone is very, very, very critical. to optimize the health of the patient. Now, I learned from Dr. Klatz, and this is something new. Again, I'm not using any brand or anything like that or company name, but cyclodextrin, it's considered like synthetic high density lipoprotein. So what's that mean? That means if you have high cholesterol and you have atherosclerosis and you want to clear the fat, yes, increasing the high density lipoprotein will help, because high density lipoprotein is like it's a cleaner of the cortisones and extra fat, and it takes it into the liver, right? The HDL, high density lipoproteins. So they're like sweeping the cholesterol from your blood and from your blood vessels, and it gets it into the liver, so you get rid from those excess. But in case you want to add more, cyclodextrin is kind of synthetic. It's a form of high density lipoprotein. Works the same thing. It's a mimic of high density lipoprotein. And I think if we infuse the cyclodextrin with nitric oxide and thiols, and I think that would be a good idea to provide the patients. And you can both increase the release of nitric oxide, plus you can go ahead and clear the body from or help to manage atherosclerosis and hypercholesterolemia. Something that it's a good idea if we can apply this into clinical work, which we are working on. Saliva total testosterone, similar to free testosterone, abnormal level can be due to various conditions, including endocrine disorder or obesity. If it's low, you have too much of aromatase, testosterone will convert into estrogens. And definitely we need to work on that by giving the patient testosterone and progesterone, inhibit the aromatase as much as you can. And inhibit the aromatase, I mean, we have anastrozole, that's right, but I think using the most biological friendly progesterone, iodine, polyphenols, I think, and lowering and weight loss, this is the things that you need to start. And then anastrozole could be something you use it at the end of the spectrum of the management. All the time use as much as low dose and bioidentical products or supplements or natural thing, and then you move on to the big pharma product. Serum 6 hormone binding protein, high level may associate with liver disease, hypothyroidism. That's why we check the thyroid. When you do 6 hormone, check the thyroid, check the cortisone, and also do a complete metabolic panel. Maybe the patient has liver problems, and so the problem is not the gonad, it's the liver. And so doing those things and being more comprehensive, and I think this is one of the things that we learned from Dr. Patel and Dr. William. They like to look at everything to make sure that they are not shooting in the dark and they're giving the right thing. Because if you manage the root cause, if you manage the hypothyroidism, then the 6 hormone will bounce up again, and you don't need to give them 6 hormone. If they have hypothyroidism, we manage hypothyroidism. Why are we giving 6 hormone for patient with hypothyroidism? I mean, yes, you can give it for symptomatic relief, but most importantly is to manage the hypothyroidism, because that's the root cause. And then once you manage that, the serum 6 hormone binding protein will go back to normal, and then you can free your testosterone. So that's the reason, in chronic disease prevention management physicians, we try to do as much as we can. We be more comprehensive, and we follow what American Medical Association are entertaining now. They are entertaining what we call the CDPM, which is chronic disease prevention and management. They ask us to provide education and curriculum and what is chronic disease prevention management. They come up with an AMA. They came up with something that's called 360 HP, which is when you take history and physical exam, be more comprehensive, include all the systems of the body. Take the history and exam all the systems. Because if you are trying as a specialist to manage one system problem, and other systems are is abnormal, or it's sick, or it's diseased, then whatever you do to manage this system, it will not be optimizing. It will fail, because the other system could be source of free radicals, inflammation, which will aggravate the system of the interest. Let's say if you are trying to manage Alzheimer, right? And you say, oh, I'm a neurologist, I will just give them something that will increase the acetylcholine, right? That's the neurologist, right? And I will give them drug. I'm not going to mention the drugs because of the CME here, but I would give something that inhibits acetylcholinesterase and increase the acetylcholine bioavailability. That's the management of neurologists. But us, we think, oh, well, this patient may have toxins, may have fungus that aggravate, those are free radical generators, that cause the degeneration of those neurons. Patient may have leaky gut syndrome. Patient may have abnormal in their sex hormone, so they don't have enough sex hormone to express antioxidants, and that's the reason the neurons are degenerating fast. And so we go, maybe the patient is obese and estrogen dominancy, and there's too much of estrogens and cortisones. So we look at all these things and we try to optimize the health, because definitely collective management of all those free radical generators, whether it's leaking from the gut or from the toxins or from the fungus, or you have some metabolic errors. That's the reason when we manage chronic disease prevention management, we look at 4 pillars of 4 things, 4 pillars of management, which is restoring and modulating the redox, the metabolic, the immune. And then after you manage all of this, then you're going to go ahead and start giving some regenerative therapy, so you can restore the regenerative status of the patient. But you cannot restore the regenerative status of the patients and giving them sex hormone, giving them exosomes and stem cells without clearing the weeds by restoring the redox and metabolic and immune, right? If you trying to give stem cells, seeds in the ground that is full of weeds, that's full of senescent cells and cancer cells and inflammasomes, it will not be as much as effective. And how we can clear this is by balancing the redox, by restoring the metabolism, by restoring the immune system. We can definitely clear those inflammasomes and cancer cells and senescent cells. And then we go ahead and give them sex hormone. Even growth hormones, if you want to give growth hormones, you don't give it randomly. Patient, hey, here's a growth hormone. No, that's wrong. Why? Because let's say the patient, you give them growth hormone and their body is full of precancers, right? Because we produce cancer all the time. And we are not clearing those cancers. We're not destroying those cancers. Those cancers we produce, and your immune surveillance will try to take care of them and prevent them from flourishing. But we all the time produce cancer, and immune surveillance, like police, they catch them and destroy them. But if you give them growth hormones randomly, without any right protocol, then there is possibility those growth hormones can stimulate those cancer cells. So what we need to do, if you want to give growth hormones, then either you do fasting for 12 hours, and those fasting will activate the AMPK, will inhibit the mTOR, and they will clear all your inflammasomes and cancer cells and senescent cells. So that's what you need, 12 hours of fasting, or 12 hours of giving them the patient mTOR inhibitors, or giving them methylene blue, giving them things that helps to clear the inflammasomes and senescent cells and cancer cells. That's what you need to do. Anything that activate AMPK, what is that? There are a list of them. One of them is metformin. And if you give the patient that, and also fasting, anything that activate the MPK and inhibit the mTOR for 12 hours, whether it's fasting or even supplement, polyphenols, metformin, name them. What other things that you want to list that helps in clearing up those cancer cells and balancing the immune system and balancing the immune, all of this would help. And then when they break their fast and they eating sugar, yes, the mTOR will be activated, right? That's good. So we end up with regenerative status. And then you can go ahead and give them growth factors. So either fasting or polyphenols or keto diet for 12 hours, that's good. That helps to activate the AMPK and have the mTOR. And then you can go ahead and give them growth factors. But giving growth factors and they're already having high sugar there, and they already have inflammasomes and cancer cells and all that stuff, I think it's not right idea. So if you give the growth factors, growth peptides, you need to make sure that those patients are having this 12 hours of AMPK activation. Amloxanox is one of them, and listed, there are many of them. Balancing your metabolism and immune and metabolic is part of clearing those inflammasomes, senescent cells, and cancer cells. So again, saliva progesterone, if it's high, it could be because we are giving it too much, or it could be because of adrenal tumor. Again, when you do sex hormone, and you're testing the patient, it's good to test the thyroid because, as we say, if you have abnormal thyroid, it may affect your 6-hormone binding proteins, right? It's not because of the gonads, it's because of the 6-hormone, because of your thyroid. So, and also if the patient is having fatigue and you want to know this, is this fatigue is because of estrogen dominance, because of low 6-hormone, or this fatigue is because of the low thyroid? And so in order to really find out exactly what's going on, we will recommend, to just add the TSH and T3, T4 as part of the routine. And especially because we are all intoxicated with halogens from the chloride that's in your water and the fluoride that's in your toothpaste, even in the water. And then you have the bromine or bromine that's in your bread. Those halogens are actually causing iodine deficiency. And when you have iodine deficiency, there's a problem because then you have too much of estrogens, because iodine is responsible to convert estrogens to estriol. And so you have estrogen dominancy. And also, if you have iodine deficiency, you have too much of active aromatase, and you're converting testosterone and also estradiol into estrogens, and you end up with estrogen dominancy. And estrogen dominancy causing iodine deficiency because it causes malabsorption of iodine. So it's like a vicious circle there. And those halogens, the chloride and fluoride and bromide, all of this will take the place of iodine and prevent iodine from as a cofactor to stimulate your antioxidants, or iodine in helping you increasing the activity of mitochondrial. So you have the mitochondrial function, you have problem with your expression of antioxidants. Why? Because all those sites of the cofactor that's been, the iodine is combining. It's not necessary that the iodine is only for making thyroid, but also it has extra thyroid function. It's a cofactor of antioxidants. It helps the mitochondrial function. It's very powerful antibiotic, and it clears the body from virus and bacteria. So these halogens that we are being intoxicated with, well, it leads to iodine deficiency, estrogen dominancy, and so we need to measure that. And but too much of iodine, above 10 milligram a day, I don't recommend that, because especially without selenium, it may activate the TH17 and thyroid and lead to Hashimoto's thyroid. So we need to have that a range from 3 milligram to 10 milligram, and don't go too much. And also, when you give iodine, it's good to give selenium as well, because both of them, they are cofactors in expressing antioxidant and functioning of the antioxidants. So T4, T3, and reverse T3. People, they will know what is reverse T3. When you have oxidative stress, whether it is rheumatoid arthritis, not necessarily the thyroiditis itself, but if you have inflammation from outside, right? Rheumatoid arthritis, autoimmune, you have too much inflammation, you have oxidative stress, regardless of the source of it. This inflammatory status, and the best way to diagnose oxidative stress and your general body inflammatory status or redox status is to use endothelial function test and autonomic nervous system, because endothelium are very sensitive when you have too much of oxidative stress or free radical generators and inflammation. And so this is like stethoscope when you use endothelial function, and autonomic nervous system are very sensitive too. So if you have too much inflammation, too much of oxidative stress, you have too much of sympathetic, and then you have this vicious circle, and you have imbalance in your autonomic nervous system, abnormal autonomic nervous system, and you can see that in the heart variability, right? Your autonomic nervous system are not functioning, and they don't really cause increase and decrease in your heart rate as normal, and your heart rate is kind of more fixed, because there is no sympathetic parasympathetic variation there, because they're sick. They don't produce enough of sympathetic, especially the sympathetic. And so that's the reason we use this. And it's like a stethoscope for the mainstream medicine, hearing the sounds of the lung and the heart, right? Sounds, that helps in diagnosis. Yeah, for functional medicine, endothelial function tests and ANS, pseudomotor, especially endothelial function tests and ANS, this is the stethoscope to measure the status, your oxidative status and inflammatory status of the body. And so I do recommend strongly that every integrative regenerative doctor, they have to have this tool in their office, regardless of where they can bring it, because we're not here to promote any company. And they have to have it. Otherwise, if you don't have it, you're not an integrative doctor. Because what they're doing as integrative doctors, you are screening for all those free radical generators and inflammation, and you're trying to put it down. But how you know you put it down? You give 6 hormone, you give supplement, you give detox, you manage the fungus, you manage the metabolism, you balance the immune system. How you know that there is no more oxidative stress and inflammation is by endothelial function test and by autonomic nervous system balance. Now, if you have, then what will happen? This oxidative stress or inflammatory process, it affects also, see, that's another thing. And I think that's the reason why Dr. William Bill, he likes to measure T3. Because if T3 is high, that's mean there is inflammation somewhere that is affecting the iodinase enzyme. You know, the iodinase enzyme that converts a T4 to T3. If that enzyme is oxidized, they start acting weird. Either they don't produce any more T3 and you will see the T3 is low, right? Or if they produce T3, they produce a wrong T3. So let's say my arms and my legs are the iodines of the thyroxine, right? Normally the T3, let's say, you know, they will remove my right iodine. That's the normal. And the left is, it has iodine. But the reverse T3, oh, the iodinase enzyme, they become abnormal, like a drunk enzyme, and instead of removing the right side iodine, they move the left side, and you end up with a T3 that's a mirror of reverse T3, that's a mirror of the normal T3 that's functioning. Any change in the shape or just removing one iodine in the wrong position from right to left or left to right, it gives you a reverse T3, and that doesn't function, does not work. And so if the reverse T3 is high and the T3 is low, that means you have some sort of inflammation in the body, and you need to take care of that inflammation. Now, some doctor will say, well, I'm going to give them T3. Yeah, but if you manage the inflammation and you find the source of inflammation and you manage it, then the iodinase will work again and start producing naturally your T3. And that's not good if you continue giving T3, because you end up causing more of sympathetic overactivity. Anything that increases the thyroid, you increase the sympathetic, and sympathetic causes inflammation and will cause a problem with iodinase enzyme again. So we make sure, you know, if you give T3 for symptomatic relief, but once you start figuring out in managing the oxidative stress and inflammation, you may need to wean those T3 because your body is now, the iodinase is recovering and it's producing T3. And too much of T3, and if you continue, it's not good because you end up with hypothyroidism, sympathetic overactivities, and inflammation again, which will compromise the iodinase enzyme again. Sometimes I will just fix the inflammation. I don't need to give them a T3, but some doctors, they insist of giving it. It's all about the options here, you know, another word, what the doctor prefer. For me, I will address the inflammation, and I will fix that because I don't want to give the patient T3 for a long period of time and they end up, what we're giving is causing hypothyroidism and more oxidative. We're going to learn that from when we study the clinical cases. Iodine is very important to measure. Again, patient with estrogen dominancy, they have iodine deficiency. Why? Not just because halogenes is taking their place and preventing it from being absorbed, but also it's because estrogen dominance itself is causing malabsorption. And so it's very critical to measure iodine as part of 6-hormone therapy. And also we're giving iodine to balance the 3 forms of 6 hormones of the estrogens, which is the estradiol and estriol, estrogens, and converting them to estriol. Yes, in case, you know, it's good to check that thyroid antibodies if you suspect that you would have patients with hypothyroidism or even hyperthyroidism. You know, we want to check the antibodies to see if those antibodies are stimulating the thyroid by combining with their receptors and giving you hyperthyroidism, or it's damaging the thyroid and it's giving you Hashimoto thyroiditis. Now, when you manage Hashimoto thyroiditis, we're different from the mainstream medicine. We're not just giving them thyroxine, but also we try to fix the inflammation itself of the thyroid. And how we do that? Low dose naltrexone, polyphenols, balancing your 6 hormone, right? If they have iodine deficiency, you may need to give that, but not too much. If you give too much, you aggravate the Hashimoto thyroiditis. And you give selenium. So we try to balance and restore the immune. That's part of chronic disease prevention management. It's not just restoring the metabolic by giving thyroxine, but also balancing the immune system. Also balancing the redox, the inflammation, the oxidative stress. If there's any leaky gut syndrome, take care of it. If there's fungus infection or viral infection, take care of it, because all of this can contribute in the inflammation or aggravate inflammation of thyroid. And some people, you know, the thyroiditis will resolve and their thyroid will start functioning just because you're addressing the balancing of the immune and the metabolic. And also possibly you give them some regenerative therapies as well. So that's the difference between us and the mainstream medicine. Mainstream medicine, they fix the metabolism, which is they're giving them thyroxine or giving them acetylcholinesterase in case you're managing Alzheimer. We manage the inflammation, the degeneration. We look for the root cause of what speeds the process of degeneration, what could aggravate the inflammation, and we need to address it. And if we find it, and we screen it, and then we work on it, right? Okay, and that's what we call the health optimization, using those 4 pillars. And I need everybody to learn this. You need to check the immune, metabolic, redox, and then regenerative. This is very important. And all the drugs out there can be categorized, their mechanism of action, into those 4. Give me any drug. I can tell you whether this is causing modulation of redox, restoring or modulation of the metabolic, or regenerative, or immune. All of the drugs can be classified under this 4. Some of them, they have 2 things. Like you can say vitamin D, it increases the expression of antioxidant. It balances the redox. But also vitamin D inhibits the Th17. It balances the immune system, right? So see that, you know, how they can do 2 things. And sometimes it's difficult even to categorize them, which one exactly. But I would go with vitamin D as redox balancing by expressing antioxidant.
It's been 1 hour, so
We have
Maybe.
how many hours now?
it's been 1 hour, maybe ask.
We're going with cases.
Questions. Sam?
Yeah, okay. Well, let's do questions and then we do some cases. We are 1 hour, which is good. Then we can go and do some cases. But do we have any questions? Dr. Joseph, do you want to add something?
Nothing at the moment. I was just looking at the iodine or low iodine levels, and this article is talking about in association with ductal hyperplasia of the breasts, perilobular fibrosis in the virgin mammary glands. Similarly, supplement of iodide in patients with fibrocystic breast disease is accompanied by remission of symptoms as well as significant anti-inflammatory effects. So, you know, when you're thinking about, I never would have thought about that before, especially when I did more family practice, in a family practice setting, that fibrocystic breast disease, that there could have been an association with low iodine levels. And in all actuality, probably most people, I would think, based on what I'm learning so far, have a degree of iodine deficiency because of it's being overridden by fluoride and bromide and chlorine. And so it makes sense. And I think that's the main thing is that even though this is not easy to put all these things together, quite like Dr. Halasa does, it does make sense.
Right. And iodine, the mechanism of how it helps in breast cysts and basically any excessive or proliferation. Part of it, iodine itself works as apoptosis for any abnormal cells, including those cyst cells. And iodine also induces differentiation directly. So apoptosis, differentiation. And the third thing, iodine helps to convert this estradiol and estrones into estriol. And we know estradiol and estrones, they are proliferative drug. And they shifting it to estriol, which is differentiating drug. So with all this mechanism, iodine will be the good option for managing anything that's abnormally growing, whether it's cyst or tumor or anything like that. So I think it's a very powerful
even prostatic hyperplasia.
Right. And prostatic, you can add iodine, the same thing. You get rid from the estrogens by moving it to estriol, but also iodine itself works as an apoptotic drug, helps to activate the mitochondria. It helps to induce apoptosis, and it helps to shift the estradiol and estrogens into estriol as a differentiating effect that the iodine does. So from now on, we learned that the most powerful chemopreventive supplement, even better than polyphenols and methylene blue, is iodine. And everybody needs to be on that 3 milligram minimum dose. And that's the reason why Asians and the Westerns, that the Asians have less cancer, versus the Western people. And because they're eating too much of seafood and all this sweetness, what do we call it?
Seaweed,
Seaweed. Yeah, the one that you mix, you're putting it in your blender.
yeah, no, I mean, I get it right here. It's
Right.
sea moss.
Yeah, without mentioning the product, because we are here in the
Yeah,
CME.
Yeah, sea moss, I mean,
It's a general name, right?
is
Okay.
really,
As
really
much
good
as we
for
can
iodine.
use general terms, not promoting any company or any label, we're good doing.
Dr. Halasa, you're right, but when you're talking about ordering the salivary hormones, there are many labs, but ZRT lab appears to be good on paper. So have you seen the ZRT
I
lab?
don't want to mention any name of the labs just because
But
it's
you can mention it when it comes from the public. You cannot.
Generally is that we will look for the best, but according to the CME, we cannot promote any company over others.
No,
Yeah.
I'm not asking to promote.
Right.
I'm just saying that, have you looked into this lab's results? And what have you found? I'm not promoting it, but I'm asking you that.
Well, we just learn and we just start with them, but we don't have any, whether positive or negative yet, but we can take this conversation after the CME. Yes. I will respond to you. Again, yes. Any other questions?
Yeah,
We're good?
question on the mTOR. Do you use recommend rapamycin type of drug for
I don't
well,
recommend any brand drugs or whatever, but
I don't mean it as a drug. Is it a generic? Is it a generic or is that a real
yeah,
drug?
mTOR's inhibitors, there are many of them out there.
Are there? Oh,
I
didn't know. I'm sorry, I didn't know that.
Yeah, we will talk about it. mTOR inhibitors. I'll give you a list of them. But because the names are commercial and even generic, not allowed. But we say mTOR inhibitors. The
Okay,
list of them, I will
thank you.
talk to you about it later.
Thank
Yeah.
you.
But
Okay,
very important to give them, if you want to give growth factor peptides, you don't just give it like this. You just need to have at least 12 hours of mTOR inhibitors and AMPK activators for 12 hours, whether it's fasting or supplement or drugs, and we have many of them. And then you go ahead and say, I'm going to give growth factors, because then I'm okay with apoptosis, 12 hours of apoptosis of citizen cells, cancer cells, and inflammasomes, and then 12 hours of regeneration. And we need that cycle. That's the reason why, fasting is a good thing. And it used to be a religious thing. Every religion has some sort of fasting, whether you're Jew or Muslim or Christian or Buddha or Hindu, they do fasting. All of them, they common thing. And it's something traditional, ancient thing. And it's a healthy thing you do, because that fasting helps to activate the AMPK, inhibit the mTOR, and clears the weeds. So when you eat after the fasting, you stimulate your mTOR, but you stimulate your stem cells. You're not stimulating your pre-cancer cells and those things. You're stimulating your stem cells and you're regenerating. And so I do recommend fasting and also taking polyphenols. Polyphenol is a very good AMPK activator and inhibitor. So you can use those names, but
thank you.
right. Any other questions? Are we all happy here? We understand that we need to change from giving sex hormone, even bioidentical randomly without checking the patient, and also making sure it's balanced versus just giving it like people are giving those pellets. I mean, I feel sorry about people who are overweight, especially men, and then you give them pellets of testosterone. You're killing that patient. Because where the testosterone will happen, what will happen to those testosterone? The fat tissue, the aromatase will convert them to estrogens. And they end up with estrogen dominancy, estrogens, and cortisone dominancy, and they end up with prostatic cancer and all this stuff. So it's not just say, oh no, it's bioidentical. Oh no, it's bioidentical. I'm giving estradiol for the women without giving her progesterone or without giving iodine. She may end up with endometrial cancer. She may end up with ovarian brow cancer. She may end up with breast cancer. Why? Because it's not being given to her balanced with the right ratio between progesterone and estradiol, and making sure the estrogens and estradiol is also balanced. The estrogens and estradiol, you need to get at least less than 2, because this estrogens is proliferative and inflammatory. And think about it, you have proliferation and inflammatory. What will lead that? It will lead to breast cancer, will lead to endometrial cancer. You don't want that. So we need to learn how to balance it. We need to learn how to do the ratios. And those labs, not just giving us normal range, because we're going to see cases where they're already normal ranged, right? But the ratios are off. So we're going to ask the labs to also indicate the ratios and making sure that, the ratios is being balanced by the right way of doing it.
What about
Okay.
iodine in Hashimoto's disease? Can you use it?
What do you mean?
Can you use iodine in patients with Hashimoto's disease?
Yeah, so if the patient is deficient, if the patient is deficient, just normalize the range of it. But again, if you go above 10 milligram per day, you may aggravate the Hashimoto thyroiditis because it does activate the Th17.
I think the question may be talking about, well, what if they're on thyroid medication and then iodine is started? Is that going to push them into hyperthyroidism?
Well, again, you do things and you still balance it and you monitor it. You don't just do this. But again, if there are iodine deficiency, maybe the iodine deficiency is causing the hypothyroidism and it's causing the immune imbalance. The iodine needs to be normalized. That's for sure. And even if they have thyroiditis, you can still give them iodine, but not at high dose, and give them selenium at the same time. And for the sake of just be conservative, just give 33 milligram a day if they're iodine deficient. But if you do too much of iodine and without selenium, you may aggravate the thyroiditis because it can cause activation of Th17. So that needs to be, we need to have more researches as well. This is kind of a new field and we need to have more studies and research there. Anybody is, again, I need you to be critical, whether it's negative or positive. If you have correct information and better information that you're receiving, I will be holding you accountable, because this is a group discussion for the doctors to verify information. And if I am wrong, just say I'm wrong. And I will rectify myself and correct myself. Everybody can make mistakes. But what's wrong is for me to not allowing you to correct me. And that's happening in many other conferences. So this conference is about verifying the information. So Dr. Patel, if I'm wrong, just say wrong and fix it. If Dr. Joseph, you see is wrong, just go ahead and fix it. So this is how you obtain CME and education that's being reviewed. What's being a reviewed lecture or reviewed articles or publications is that all the doctors in the setting agree to this protocol or this way of doing it. Again, let's go to the cases, because we're going to go through 10 cases and then we will end up at 10 p.m. Patient, female, 42 years old. Chief complaint is fatigue, weight gain, irregular menstrual cycle. Now, this could be because of abnormal sex hormone, but also it could be a thyroid problem. That's the reason we like to all the time measure the thyroid here. And in those cases, if they don't have the complete metabolic panel, I will do that as well, because we know that if you have liver problems, you may also have sex hormone balance or abnormal in the sex hormone. So complete metabolic panel, sex hormone panel, and thyroid panel, and you can add cortisone as well panel. because all of those can lead to okay, let me see add here. It can lead to fatigue, right? And brain fog, right? And once you balance their sex hormone and you balance their thyroid and you give iodine, at the end of the day, you will see that the brain is being cleared. Lab results: saliva free testosterone is 15 picogram. It's within normal range, 5 to 50. So saliva total testosterone is 35, within the normal range. Serum sex hormone binding globulin, it's around 25. That's okay, within the normal. Saliva progesterone is 80. 80 is low normal. The normal is 75 to 270. This is saliva, not blood, by the way. And I like to be going to 100 and above. So I will definitely add progesterone to this patient. Saliva estradiol is 2.5. I think it's good because 1.3 to 3.3. Saliva estrogens is 60. That's high normal. I like estrogens to be less, especially we're going to see here. This is what I need. Although it's normal range, it's 30 to 70, high normal. But if you go to estradiol, how much is estradiol? Is 2.5. And we want to keep the ratio here, as I said, less than 2. So in this case, yeah, there is some estrogen dominancy here. And even if you go with the saliva here and say, okay, well, estrogens is 70 over 2, let's say 35. So 60 over 2.5 is 330. It's kind of in the upper limit, because how I can know, because maybe the blood, and when I'm talking about blood, it's different from saliva here. So how you know the normal ratios? See, you take the max of estrogens. Now the saliva is different from the blood here. The max of estrogens here is 70, right? And the low is 1.3 of estradiol. So I will do 70 divide with 1.3, around that. And anything above that, above this ratio, I consider it as estrogen dominancy. And this now in blood, you will see it's the ratio, the normal ratio has to be less than 2. But in saliva, it seems like I can go with 70. Can we do 70 divide 1.3? How much it comes out? Let's do that, right? And come up with that, because then we can come up exactly for saliva what will be the ratio that we consider it as normal.
54.
54. Okay, so 54, and then that anything above 54, right? I will consider it that the patient has estrogen dominancy. This is for saliva, and the blood is different. Now let's go here. 60 divided with 2.5 is 30. So around that. So in that case,
I thought it's supposed to be 2 to 1.
yes, 2 to 1, but that's for the blood. It seems like here in saliva testing, it's a different calculation. What you do in anyone you get the ratio, you take the max of the estrogens and you divide with the lowest of estradiol. And we can apply that for any ranges here. Okay, so let's go ahead and see what is the DHEA here. It's 5 nanogram. It's within the norm here, 2 to 3. Saliva cortisol is 0.4. That's okay. The TSH is 4.5. Oh, that's high. So here we can think that this patient has hypothyroidism as well. And I think the reason mainly this fatigue and weight gain in the irregular menstrual period is just because the patient has some sort of hypothyroidism, because the TSH is high and T4 is kind of low normal, and the T3 is also low normal here, and reverse T3 is 250, which is high normal. So it seems the patient here has hypothyroidism. Iodine is 50. That's kind of low. 100 and 200 is the normal. Thyroid antibodies is positive, so that's very clear. The patient has Hashimoto thyroiditis, and that's the reason the patient has overweight. So Here, this patient, we may consider treating the patient with, yes, and in this case, we give them iodine, by the way, even they have thyroiditis because their iodine is low. And we need to consider giving them T4 levothyroxine. And I think doing that and possibly giving some progesterone there just to keep the ratio within the norm. I will give progesterone. I will give thyroxine, and I will give iodine for this patient. So let's go ahead.
Or estrogen dominance, did we determine?
Yeah, well, we can determine that because of the ratio between progesterone and estradiol here. This one has to be above 100. So yes, it is estrogen dominance.
But this is saliva though, does that change it?
No, the saliva does not change.
Oh, wait,
but
so progesterone to estradiol is.
it
should be
still
100?
needs to be above 100. So I will give this patient progesterone, and I will give them, let me see here, how I can remove this. Okay, here we go. And I will give them, so the treatment plan based on ribosol, which indicate positive hypothyroidism, low iodine liver treatment plan may include thyroid hormone replacement therapy, right? That's what we do, iodine supplement. What else? I will give progesterone for this patient just because there is some sign of estrogen dominancy here. Do you want to give estradiol here? It's 2.5, 1.3. I want to give, I'll give progesterone for this patient. And that's what I will do. Anybody wants to do something different?
That's only like about a 40-to-1 ratio versus a 100-to-1 ratio.
Which one?
The progesterone to estradiol is 80 over 2.5. I was saying it's about 40.
Right.
And maybe a little bit less, like 35-to-1 versus 100 should be 100-to-1.
So it should be 100-to-1. So the patient does have estrogen dominancy here.
Yes, I mean, if that's,
So I will give progesterone and I will give iodine to get rid from the estrogen dominance, and also I'll give sex hormone. You got my point? But estradiol is 2.5, so that's 1.3 to 3.3. That's kind of within normal, right? If we consider that.
so
normal.
progesterone is low normal, but
But the ratio here,
yeah,
it need to be kept above 100.
yeah.
I will give progesterone for this patient. Okay, and and I will give them we'll give them thyroxine, and I will try to fix the inflammation also as well by giving them low dose naltrexone, polyphenols, right? Because of the thyroid antibodies.
Recovering with the iodine and getting the progesterone
Right.
more normalized that's going to also reduce the risk of fibrocystic breast
Right.
disease and
Exactly.
and risk of breast cancer.
And it helps to decrease the ratio here, because estrogens here, she said the ratio, it's not, well, it's okay, but again, you want to give the progesterone because it does help to put some break into the inflammatory process of estrogens if there's any estrogens excess there, and have the aromatase, and also if there's weight gain. I think when you do the thyroid and giving them, their spontaneous, their weight will go normal just by giving them thyroxine. It makes sense?
Yeah.
Right. But also we work on the inflammation. So that would distinguish us from the mainstream medicine. We'll just give them thyroxine and go home. Us, we give progesterone, we give them iodine, we give them polyphenols, and we give them low dose naltrexone. Any questions here? Are everybody's happy here? Now, I want to make sure that everybody is getting the link for getting your CME. Did everybody has it? It's in the general chat. And if not, just text me and I will send you the link where you can get your CME. And I'd like everybody here in this room just to keep this business, in other words, this weekly webinars going. Then I need everybody, even if you don't want the CME, just go ahead, contribute $30 cost of the CME, receive it, or just contribute and keep this weekly webinars going. Did you, everybody has it, right? Any questions here? Can you confirm? Can you hear me, guys? Am I here?
Yes, can
Yes.
hear you very clearly, Dr. Halasa.
Okay, good. Any questions, just let me know. Okay, let's go
There's
ahead.
a question in the chat.
Yeah, it's in the chat room. Did you see it? Is it there in the general chat? Let me see. Can you see it in the general chat or no?
Don't see it.
I cannot see it.
Oh, you cannot see it. Okay, let me go ahead and just add it right now. So people will have it. Because that's,
It was put in at 7:45, so roll your bar up or down in order to see it, perhaps.
yeah,
Recording in progress.
okay.
Yeah, what happened with me is I got bumped off here, so now I can't access what was happened before I got bumped
I
off.
will give it right now for, oh, let me see. I will give it right now for everybody, and I would recommend everybody to do it because you're getting your CME, and that helps you all the way. You know, the CME will be more appreciated the more credit you have. Everybody has it now?
Yes.
Yes, okay. So please do it. Let me get this out. Just to support the rule and keeps things going.
I can see the actual questions.
Did you
The
see
first
that
one is
CME link? You just go through that
yes.
question, right, and answer them. And then you get your CME immediately. I mean, they send it to you to your email, and you got the 2 hours CME. And this helps a lot, you know, instead of going to conferences, which I do recommend sometimes, just to see what's going out there and, you know, and what's the updates in terms of the companies or not. But
Would you like me to read the question real quick?
which question? You mean this case?
There's two questions. This is good information. Any thoughts on xenoestrogen effects and treatments? And the second question is, would you give DHEA and why levothyroxine rather than Armour?
I will go ahead and answer the levothyroxine versus the Armour. I have patients who's been taking Armour and they develop hyperthyroidism for a long period of time, and it was not a good experience. I don't recommend Armour just because it's not predictable. Maybe the old version of Armour was better than the new ones, but because it's not predictable and it's not giving me the level that I want and inhibiting the TSH, the thyroid stimulating hormones, and there is some says it may aggravate the thyroiditis because it's coming from the pig and it may have some impurity there where it will cause autoimmune. I recommend levothyroxine because of that. So that's my opinion. Again, I'm not a savvy integrative doctor. I'm combining both conventional, and if I see the conventional better than integrative, I will go with the conventional. So I recommend levothyroxine. I myself am taking levothyroxine. I did have prostate thyroid cancer and removed, and I am on thyroxine, and I'm on levothyroxine, and I do recommend levothyroxine. What's the other question? The xenoestrogens, right?
Yes.
Okay, so the xenoestrogens, they are aromatase stimulator, and they will induce more conversion of testosterone into estrogens. And the estrogen mimics or xenoestrogens, they will function like estrogens, and they will cause estrogen dominancy. They exactly same function of estrogens. They're weak estrogens, but they are inflammatory. They're not anti-inflammatory. The same like estrogens. And inflammatory and proliferation equal to cancer and inflammation. And it will trigger the cortisones, yes, because this xenoestrogens will shift the steroid pathway, and instead of making sex hormone, they're making more cortisol. Making cortisones is not good because you switch and you become cortisone dominancy, And then their cortisone causes degeneration. Yes, it causes anti-inflammation, but it causes degeneration, and cortisone compromise your cytotoxic T cells, your immune surveillance against cancer, and it puts you at high risk of cancer. That's the reason why we all have the risk of having cancer throughout our lifespan. Do you know how much? 50%. A flip of the coin. Everybody here. And we need to lower that risk as integrative doctors. And how you lower that risk? By health optimization, by weight loss, by making sure you manage estrogen dominancy. Because estrogen dominancy, 99% of us do have some sort of estrogen dominancy if you don't check it and fix it. All your patients, you need to go and check them for estrogen dominancy. And how you know that? If you're using the saliva, as you said, you go ahead with the ratio between the progesterone and estradiol, and if it's less, it's less than 100, you may need to give progesterone and iodine immediately. Check. This is a career for you guys. I'm telling that to Dr. Juice, man. All your people, all your patients, you need to check if they have estrogen dominant syndrome from now on. Because what has been done before is completely wrong. It's not being balanced. It's just giving, I'll give them estradiol, give them the pellets. Yeah, you give them testosterone pellets and he's overweight. What will happen to those testosterone? You give them estradiol and the woman is overweight. What will happen to the estradiol? It will convert to estrogens. Without giving them progesterone, and without giving them iodine, without giving them polyphenols, and without working on their weight loss, you are inducing cancer and inflammation and damaging to the patient. Without knowing, you think, oh, I'm fixing it. Yeah, you don't have sex hormone, it's a problem. You end up with cortisone dominancy. And you end up with obesity because sex hormone helps to prevent metabolic syndrome. And metabolic syndrome is obesity too. What is metabolic syndrome? Obesity, hypertension, high cholesterol, right? Atherosclerosis, insulin resistance, diabetes. That's metabolic syndrome. Low sex hormone leads to metabolic syndrome. And if you give the sex hormone in the wrong way and you're giving it without being balanced, you're also introducing metabolic syndrome. Either way, it's a problem. Estrogen is a good hormone, yes, it does help, but it has to be balanced. If it's excess, it's not good. And that's why sometimes we call the estrogen is the good devil. It's good if it's balanced, but it's devil if it's hyper, it's overactive, or it's too much of it, right? There's an article about it. Estrogen is a good devil, right? And you go and PubMed it and you will find that. So let's go ahead with another case, 55 years old.
Dr. Halasa.
Yes.
I have a question. So when you see your male patients, do you check the DHT?
Yeah, you can measure the DHEA. Is that what you're talking about?
No, the DHT, which is the dihydrotestosterone.
Yes, you can add that in your measurements. And if it's too much and excessive, it's not also good. But iodine and progesterone do inhibit the conversion of testosterone to dihydrotestosterone, right? Or dihydrotestosterone, the DHT. And that's the reason,
I agree with that. Yeah. The other question I have
let me add something very important. When you see somebody is bald, hair loss, female or male, right? And you want to help them because of the DHT excessive, and because the follicles are sensitive to DHT, not to testosterone, to DHT. So you do topical progesterone lotion along with minoxidil, and you put it in their hair, and that would, along with iodine supplement, and that helps to regrowth their hair and better than just giving minoxidil for those patients.
Yeah, so, the minoxidil actually is not a good idea, because there's a condition called PFS. And so if you give it to young males, that can shrink their testes so they're not functional. So you have to be very careful giving the minoxidil. Now, one other question, do you check any of the toxins in the patients with Hashimoto's or any of your patients with thyroid, autoimmune thyroiditis?
Okay, let me make sure that that when we do chronic disease prevention and management, we know the 4 pillars in any inflammation and any disease is there's 4 pillars: the metabolic, the immune, the redox, and the regenerative status. Now, where the toxins is got under what? Under redox. Yes, any inflammatory diseases, you need to check those 4, and especially the toxins, because the toxin is under the redox. If you have toxins, you have free radical generators, then you have redox imbalance. Whether these toxins are heavy metals, whether this toxin is mycotoxin from the fungus, whether it's spike protein, all of them are causing redox imbalance. And also they can cause immune imbalance as well. So it's part of the management of chronic disease prevention management is to screen all the free radical generators, all the inflammatory generators, all the immune imbalance. It's part of it. And also you need to do the degree of function test in the beginning that helps you when you're giving those treatment, you know whether you are effectively able to detox the body and balance the redox and immune. If your degree of
correct.
function is
So
still on fire,
this
that
young
means
lady,
something is missing. Right.
Yeah, this young lady that had the Hashimoto thyroiditis,
Right.
did you do this toxin check?
But this is yeah, you're asking me, those are hypothetical cases. And we are focusing on 6 hormone. That's what this lecture is all about. But
Okay.
yes, indeed, when you see inflammation or Hashimoto thyroiditis, you need to screen any inflammatory, any infectious, any toxins that may be the root cause of the inflammation of the thyroid. I think Dr. Joseph have a very nice say about, those virus and Lyme disease and infection. All of this can be caused the Hashimoto thyroiditis or imbalance the immune system. And balancing is very important. Even if you balance it with naltrexone, you need to find out the sources.
Yeah, I mean, I always get an array 12 that does give about 30 different pathogens to see if any of them are active, like Epstein-Barr, herpes type 6, if there's mold. And then, of course, for the immune status, I'm checking the lymphocyte map, which gives me all of the markers, the lymphocyte count compared to the white count, Th17, Th1, Th2, NK cells, CD8 cells, and gives me a very accurate, shows all the polarities, like looking at, many different windows of some are going to be higher in comparison to others, and based on those patterns, points to what could be happening. And then the heavy metals, I'm still trying to look for the best test. I know there's an oligo scan, and some people are doing the hair test, but I'm at the point now, intuitively, I'm at the point of believing that everybody has a degree of heavy metal absorption and toxicity. It's just that some are feeling the effects more than others. And so I'm working on having a generalized sort of approach to detoxing and binding heavy metals as part of my overall treatment. Whether I'm targeting and not necessarily targeting any one heavy metal at this point, unless somebody is having extreme symptoms that point towards something unusual, then maybe consider checking for like uranium or more so for mercury specifically. That's where I'm at right now.
Yeah, so that is correct. I personally, when I treat Hashimoto's, the prevalence of these autoimmune diseases is very common in women than men. So one of the major issue is xenoestrogen. So I give them an estrogen-free lifestyle. I do the detox, clean them up, and making sure that the thyroid antibodies are coming down. So you have to follow the antibodies, whatever you're doing, making sure that these antibodies are going down, so then it doesn't continue to impair the thyroid.
Right, that's the difference between you and the mainstream doctors. The mainstream doctors with Hashimoto thyroiditis, give them the thyroxine and forget about what caused it, because they will say eventually the thyroid gland is going to be destroyed by the autoimmune. As integrative doctors, no, we think that we can save those cells, and that's been stunned by inflammation by restoring the balance of the immune system, by giving them naltrexone and detoxing the body, looking for any pathogens that aggravate the inflammation. All of this will help to possibly lower the antibodies.
I have a question. This is for Benal. Did I pronounce it right?
Dr. Tano, yeah, Benoit.
Yeah. And which test specifically are you getting to measure xenoestrogens? Is this measuring other toxins?
Yeah, I measure other toxins. For instance, the heavy metals and stuff. It's not your CME. Genova, for example, has some testing. Doctor's Data has some other things that you can measure. So there are many other labs that can help you check the levels of the toxins in people. And once you have that, then you can do the detox appropriately.
Do we have a lab that regardless of the name of it, I don't need to mention, but do we have a lab that measures xenoestrogens?
Yeah, but so one of the things that some of them measure glyphosate, for instance, which is the big one.
Okay.
Because in the Hashimoto's, realize that glyphosate affects the thyroid because glyphosate reduces the aromatic amino acids, which is the phenylalanine, tyrosine, and tryptophan. So
Right.
when those go down, then you're going to have hypothyroidism as a result. So by knowing exactly what the glyphosate is doing or how much glyphosate they have in them, then you can probably take care of it. And they have some.
Yeah, I know the glyphosate, there is some test to do that, but I don't think,
Yes.
estrogen, we have a test to detect that.
Yeah,
Anybody knows? Let me know.
I'm not sure about that.
How do you
Yes.
feel about say a general approach like celery juice, like 16 ounces on a regular basis on an empty stomach in the morning? Now, this is one of those areas.
But celery, so Dr. Joseph, celery is a phytoestrogen. So that one is actually on my bad list. When people have Hashimoto's, I have a whole list of xenoestrogen and phytoestrogen that I tell the patient not to do. And parabens, fragrance, mineral oils, petroleum, many of those things that are xenoestrogen. So they can remove those from their lifestyle and they will do better. And the phytoestrogen, even garlic is a big phytoestrogen. So is a lot of
I think
these.
there's a difference between phytoestrogen and xenoestrogen.
Yes.
Right. And phytoestrogens
Are you talking about
a little bit different. They
androsterone?
no, phytoestrogen is
like a soy. Soy is a big phytoestrogen. It has a genitsin and cadsen that are phytoestrogen. But soy is the number 2 GMO in the country.
But I know that phytoestrogen inhibit the aromatase, by the way. You know that? Like xenoestrogens stimulate the aromatase, but phytoestrogen inhibit the aromatase. And the fact is that phytoestrogens, some of the articles do recommend it. It helps in estrogen dominancy syndrome.
Well, no, actually it's not. So if somebody has an estrogen overload, and I've done that over and over again.
Yes.
Yes.
Kind of, yes. But if you add
if they have an estrogen, estrogen overload, and you giving them any phytoestrogen like soy, for instance, they're going to do
it may aggravate. That's true.
Yes.
So what would be the better choice then, Dr. Tano, in your opinion, to detox from xenoestrogens?
Oh, you're asking me what I use?
Yes.
Oh, so Orthomolecular has like Core Restore that they use. Yeah, they have Core Restore that they use for estrogen detox, and that is good. So those of you who are listening, you can.
And what's the mechanism? Is it the charcoal?
Oh, it's a supplement, but detoxify the liver. And remember, everything goes through the liver, so they clean the liver, and the liver can clean up the estrogens.
Is that cholestyramine? Is that what it is?
No, it's not cholestyramine. it's a whole phase 1, phase 2 detox of the liver, and they
Okay.
combine that. So just check Core Restore, and you will see the composition of it.
Okay.
Okay, no, thank you.
Well, sweating is a good thing too, you know, sauna and sweating and zeolite. I think if you sweat and do the sauna, we'll definitely have to get rid from all those fat soluble toxins, including the organophosphorus and xenoestrogens. One way of doing it naturally. But yes, if there's any chelation, which is very difficult to get the chelation for fat soluble toxins. But sweating, weight loss is one way to go. So we have a case here. It's 55 years. Chief complaint: decreased libido, muscle weakness, and difficult concentrating. Lab results: saliva-free testosterone is 60. I will go if there's. I will go more if there's any. That's the kind of low, normal kind of. Saliva total testosterone is 400. I'll go more for that. Serum sex hormone binding globulin is within norm, 40. Saliva progesterone not typically measured in males. Well, I will measure it just because it helps us to balance things. Saliva estradiol is 1.4. Now, saliva testosterone is 400, and the estradiol is 1.4. That's above 20. So the patient does not have estrogen dominancy here, it seems like. Saliva the estrogens is not typically measured. Okay, estriol, what they can measure it. I don't know why it's not. Saliva estriol, not typically measured. That's not true. You can measure. Well, estriol, you don't see them much. Saliva DHEA is 8. That's good. Okay. Saliva cortisone, 0.7. 0.321. That's okay. And then TSH is 2. Okay. T4 is 1.2. That's okay. T3 is 150. It's okay. Reverse T3 is within the norm, 180. Iodine is 120. Kind of low normal. Thyroid antibodies are negative, and the BMI is 30. What do you think about this patient? Low testosterone, right? You think?
Yeah, it's due to obesity and low iodine.
Yeah, and low iodine. So I will work on the weight loss program, whether you want to go with PGL, the GLP, whether it's peptide or the supplement that increase the GLP-1, which is, we call them the Hope's flower extract. And or you want to go with acarbose inhibitor, amloxinox, naltrexone, metformin. All this helps. Bifidobacterium probiotic. Those are the program for weight loss. I will give testosterone, right, for this patient. How much I will give for this patient? We can start 50 milligram topically and then go up to 100 if needed per day. Do we need to give progesterone? Well, I don't have the number of the progesterone here. I would like to know it. And if it's low, then I'll give progesterone, but I don't know how much it is. So just give them testosterone and give them the iodine. And I think we will be doing great with this patient. Okay, so we still have 10 minutes. And I think we're done. So let's go ahead with another case. And I think then we can start asking questions. Female, 38 years old. She complained mood swinging, insomnia, and weight gain. Lab result, testosterone 10. That's okay. Total testosterone is 40. That's okay. Serum hormone binding globulin 30. That's okay. Saliva progesterone is 60. That's low, right? And estradiol is 3. Kind of high normal, and saliva estrogens is 70. That's high. So this patient is very clear estrogen dominancy. There's no question about it, right? Because if you divide 60 over 3, that's around 20. So the patient has estrogen dominancy, and very clear the estrogens is also high. So I will go ahead and give progesterone for this patient. And the patient has estrogen dominancy for sure. The DHEA is normal. The saliva cortisone is 0.6. And the TSH is 2.5. That's normal. T4, 1.1. T3 is 120. All is normal. Reverse T3 is within normal. Iodine is 100. Now, here we go. I will give iodine for this patient. I will give them 3 milligram a day of iodine, and thyroid antibodies are negative. The BMI is 32. I will definitely work on the patient's obesity because the aromatase is converting the estradiol into estrogens, or the obesity is converting the estradiol into estrogens, and also it's converting, it's causing estrogen dominancy, and it possibly, I will definitely give this patient progesterone, and I will do weight loss as well. So what we give, given an elevated estradiol level and mood swing, consider balancing hormone BHRT, addressing thyroid function through iodine supplementation. Optimize the thyroid hormone, may improve the insomnia and weight management. So I give this patient progesterone to counteract the effect of the excess of estradiol or estrogens, and possibly inhibit the conversion of testosterone to estrogens. And I will give iodine, which will do the same. Plus, it will move the estradiol and estrogens to estriol. So iodine, progesterone, and I will do weight loss program for this patient as well. Okay, we're good. So we still have 5 minutes. Any questions? Let's
Now,
do that.
when you talk about giving iodine, how much iodine do you give? Because
3
if you do-
milligram per day, up to 10. It depends on the doctor, but I will not
But
do
how
it.
do you know? How do you know they're not going overboard? Because here we don't have really a good test. In Europe, they do have a test for
There is
iodine.
saliva iodine testing.
Yeah. So I'm not sure this is quite accurate, but they do have a
But
serum
there's
test.
serum iodine too. So you can measure the iodine by the serum. And if it's low, you can go ahead and give. For this patient, I will give 3 milligram a day and see what will happen.
So
But
you
this
do that
iodine will help
occasionally.
because the patient has estrogen dominancy, and we need to move those form of proliferative estrogen into differentiating, which is estriol, and inhibit the aromatase as much as you can. And
Okay. So
do weight
also,
loss.
when you said to do weight loss, how do you go about weight loss in
So we
this?
talked about either you want to do the glucagon like peptide one, the GLP-1
Yeah.
peptide. You can do that intranasal injection. There's some form of intranasal that's coming up, or you can do supplement that stimulate the GLP-1. There's supplement, which is, we talked about the flower, which is the Hope's flower extract from Australia. And the third part is giving oral acarbose, metformin, naltrexone as a cocktail orally, or you give probiotics, piriform, Bactrim, and doing this, you can combine all of this, so you don't have this monotherapy and use a little bit of all. You can get.
So do you have any clinical trials on your own in terms of using these supplements for weight loss? Because that would be very significant if that is the case. Any of the panel here, anyone has
The
experience
supplement that the cocktail that we create, it's there. Some doctors reporting great results out of it. That's what I know. There's already some results from Bactrim. The Hope's flower extract, it's just due recently. Dr. William is reporting that it's working very good. It's in in Australia, a company, we don't want to mention their name. And the peptides, which is the P1, everybody knows it's working, and that's the reason everybody's using it. But if you use it, just make sure you're giving B6 and you're giving multivitamins and you're giving minerals, and possibly you can give also growth peptides because they are actually don't eat. So for them, it's okay if you start even giving, so you prevent the muscle wasting and bone wasting too. But if you do it as a combination, I think the side effects of the GLP-1 will be less, and also the dose of the use maybe will be just 1 milligram per mil, just 1 mil will be enough per week. And then you can go ahead and give them other things that helps. As a multi-therapy is all the time better than monotherapy. And you hit it from different directions. And very important, even if you do the weight loss that we are talking about, those GLP-1 and all that stuff, it's very important you do balancing the 6 hormones, because if you give this and without balancing 6 hormones, some of the patient, they become resistant to the GLP-1 because their 6 hormones not being balanced, or the patient has toxins or xenoestrogens. So it's very important to optimize the health of the patient as the process. And then when you're decreasing the weight and you're shrinking it fast, like what they did with the peptides, the fat will release all these toxins and they can cause kidney failure. So we make sure that you detoxing when you're doing weight loss. That's my best recommendation here. Anybody has questions?
Yeah, what were the problems with too much iodine? You said it stimulates TH17, is that what?
Yes,
Too
if
much.
you PubMed that anywhere and say the excess of iodine, and you write in front of a TH17 in PubMed, or if you have an AI, it will give you a list of publications where the excess of iodine can cause activation of TH17 and thyroidites. That's being published. And because it's being published, we don't want to go against the publications. We said, okay, just go with less than 10, 3 to 10 milligram a day, and make sure you add selenium and magnesium
Sure.
in your protocol, and you'll be in the peace of mind doing that. But I don't recommend, because there is supplements called Endora, well, regardless of the company, they're using 50 milligram daily. That's too much.
Okay.
I will not do that because there is some publications against it. I know some integrative doctors, they will say, oh, no, we know that iodine supplement is safe and you can use, well, again, I am the person in the middle.
I was gonna say, is it because the high levels, it's activating, or it's triggering arachidonic acid to form the iodo-lipid 6 iodolactone, and that's going down a pathway that would be good for cancer if it's because it's sending it through an apoptotic pathway, maybe at normal levels, but at high levels for normal cells, then that would be triggering the,
Yes, if you write down
the-
excess iodine TH17,
yeah.
you will see a list of publications that it says it will lead to Hashimoto, it will lead to thyroiditis because it activates the TH17.
Right. Thank you. Thank you.
It's triggering an oxidative stress.
Yes, it's
reaction.
increasing the inflammation. If you trigger too much of TH17, you end up with autoimmune disease.
Sure.
You end up with thyroiditis.
But through an oxidative stress pathway.
Well,
likely.
maybe even directly shifting the immune system and activating the TH17. According to there, you will see that it does polarize the immune system, TH17, if it's high. And if it's normal, it actually inhibits the TH17 and keeps the inflammation down and activate the mitochondria. So it's a good thing in that normal range. And daily of 3 milligram with selenium, I think it's a good way. Just go ahead, do that for me. Can you do that? Can you write down, Google it or PubMed it, iodine and TH17, and you will see a list of the publications there, just for confirmation. Anybody has
Thank you.
say against that? Just go up to the mic.
Yeah. One question that I have, in terms of giving testosterone, do you ever give the aromatase inhibitor, the Arimidex and stuff? You talked about that, but like in this patient,
I will use that at the last resort. We have a lot of things that inhibit the aromatase that's naturally. DEM is one. Calcium glucarate is two. What else? Progesterone, iodine, polyphenols. Why have to go that way if I have natural thing that helps in inhibiting aromatase? Now, if all of that did not work, then I will go with anastrozole, but I will not use it to the first line treatment as much as I can. In chronic disease prevention management physicians or specialty, we try our best to use bioidentical, biologically friendly drugs and supplements. And if it's not working, we can go ahead and sacrifice, just do it for a short period of time just to balance things. Then we can go to that road. But you start with conservative, iodine, progesterone, DEM, calcium glucarate, and many others, right?
yeah, of course. I'm just checking what other people are doing. I always use natural aromatase inhibitors, but I want to make sure that everybody knows how to do that.
Aromatase inhibitors?
Yes.
If you use
I'm
it,
just
you
asking a question for the
if
public.
you
Though.
use topical 1% anastrozole, that's one way of doing aromatase inhibitor instead of taking it orally. But you can go ahead and take it orally. What's the dose of anastrozole? One for oral? 1 milligram? What's the dose?
I never use it.
Anastrozole you use orally. 0.1 milligram?
I don't use it, so I
take
don't.
0.1 milligram anastrozole if you're using anastrozole.
Yeah, 1 milligram is the standard dose.
Yeah, you can start with.
By the way, I was just, in response to the too much iodine exacerbating thyroiditis, there is a very specific pathway that,
Increase TH17, right?
yeah, that leads to it. It's you know, maybe this is getting a little bit more deep than we need, but I like to know these mechanisms. It's triggering the intracellular adhesion molecule that's expressed within the thyroidal follicle cells, and that's leading to inducing the T helper cell differentiation towards TH17.
Right.
Interesting.
I think we're done with the CME. Let me go ahead and stop.
So one quick question before we go. One quick question is that many people who have Hashimoto's or thyroiditis, people tell them not to eat cruciferous vegetables. I really think it's a nonsense. What do you guys think?
Nonsense for me. The reason is that those are thiols, right? And DEM, and all of these are anti-inflammatory and aromatase inhibitor. I will, unless, you know, there is some organic phosphorus or toxins in it, it's not organic possibly, but from my side, I don't think it's the right thing. But let's see if there's anybody here has other say. I think stop the recording and you can freely talk about whatever you want to talk, business things. We're done from the CME right now.